Welcome back, everyone, to another episode of the Evidence-Based Hair Podcast. I'm Dr. Jeff Donovan. I'm a dermatologist and hair loss specialist, and I'm also the director of the Evidence-Based Hair Training Program. We currently have 126 incredible hair loss specialists from 34 countries training with us, and this podcast is the official podcast of the Evidence-Based Hair Training Program. Each week in the podcast, I review studies that are changing how we think about hair loss. I'll introduce them to you, help you make sense of them, and give you my thoughts on how a given study just might change how we diagnose or treat hair loss. This week we'll be talking about drug-induced alopecia areata. This is a fascinating subject. Much of alopecia areata is determined by genetics, probably 70%, but 30% is explained by environmental factors, and that includes infections, especially viral infections. But drugs are important triggers as well, and here we'll review two studies of drugs as triggers of alopecia areata, one by Ravapatti in the International Journal of Dermatology, and one by ISMA in the Journal of the American Academy of Dermatology. Let's start with Ravapatti's study, title, A Cross-Sectional Analysis of Medications Used by Patients Reporting Alopecia Areata on the FDA Adverse Events Reporting System. Medications can trigger many human diseases. That certainly includes hair loss. And I'm always fascinated by drug-induced diseases because if the drug causing the disease is a specific targeting drug, either blocks a certain pathway or upregulates a certain pathway, well, then you have powerful information about the potential mechanisms of that disease. And certainly that's true for hair loss. The FDA Adverse Events Reporting System, FAERS, is a powerful tool to track side effects from drugs. If patients have side effects, they can report side effects to this FDA Adverse Events Reporting database. Doctors and industry can also report side effects. And to date, there's some 26 million side effects logged on that FDA database. And so researchers often use these databases to understand medications that are causing certain side effects. And Ravapatti dived into that database to look at drugs causing alopecia areata. They found 1,331 cases of alopecia areata reported on the FDA database. Interestingly, reports are increasing dramatically over time. There's more and more entries in this database related to alopecia areata. 76% of reports are in females. Docetaxel, a chemotherapy, tops the list of 29.2% of cases of drug-induced alopecia areata in that database. But the rest are largely comprised by monoclonal antibodies. The TNF inhibitor adalimumab comes in second. That's a TNF inhibitor. The HER2 inhibitor trastuzumab, used in breast cancer, comes in third, followed by cyclophosphamide, a chemotherapy drug. Infliximab, another TNF inhibitor, comes in fifth, followed by carboplatin, another cancer drug, and then dupilumab, a monoclonal antibody blocking IL-4 and 13, coming in seventh. But monoclonal antibodies comprise 6 of the top 10 drugs. 3 of the top 10 drugs were cancer drugs. 2 of them were HER2 inhibitors, and 1 was carboplatin. ISMA performed another really nice study. This is from Dr. Senna's group from Boston. They looked at published data in the literature. So they performed a systematic review. They found 66 articles related to drug-induced alopecia areata, 102 patients. Average age of patients was 40 years, about half were female. 30 drugs were found to be associated with drug-induced alopecia areata. And here's the fascinating thing, and that is that, again, 76% of drug-induced alopecia areata cases were monoclonal antibodies. TNF alpha blocking drugs and dupilumab, the IL-4/13 inhibitor, comprised most of those monoclonal antibody-related cases. But the top drugs in ISMA's study are adalimumab, the TNF inhibitor at number 1, infliximab, a TNF inhibitor in number 2, the IL-4/13 inhibitor, dupilumab in number 3, etanercept, a TNF inhibitor in number 4, a monoclonal CD52 antibody in number 5. This is followed by drugs like ribavirin, cyclosporin, belimumab, cladribine, golimumab, another TNF inhibitor. Patchy alopecia areata was the most common presentation. So most patients with drug-induced alopecia areata, 70%, are getting patches of alopecia areata. But what I particularly found interesting about ISMA's review is that the mean time to onset is about a year. So drug-induced alopecia areata is not a condition where you get your drug and a month later you get a patch of alopecia areata. That's certainly what we would think intuitively, but it's not. Drug-induced alopecia areata can have a significant delay. What I also liked about this study is the authors review how it's best treated. 48 patients stopped the drug, thought to be causing drug-induced alopecia areata, and all had regrowth. That's fascinating because alopecia areata is not always so easy to treat spontaneously without medications. It can be, but not as consistently as in this study. And if patients continued the drug, most people didn't have regrowth. But with treatment, 75% of patients had regrowth. So all in all, monoclonal antibodies are topping the list of drug-induced alopecia areata. I think that's really, really important. These monoclonal antibodies, as well as specific small molecule inhibitors and agonists, are becoming more and more a part of our therapeutic toolboxes in all human diseases. And so cases of drug-induced alopecia areata are clearly increasing, but with more and more of these specific drugs coming to market, they may be more and more part of our hair loss world in the months and years ahead. So stay tuned and take good histories, examine your patients, of course, really well, but don't have the view that drug-induced alopecia areata should occur within months of starting a drug. The average time could be up to 1 year. Outcomes seem pretty good. If it's reasonable to stop the drug, then stopping the drug seems highly successful. But even without stopping the drug, treatment works in a large percentage of patients. Next week, we're back. This will be the month of May, and we'll be talking about minoxidil-related studies. In case you didn't realize, April was alopecia studies. May will be minoxidil, and we'll continue this alphabetical theme. June will be JAK inhibitors, and the summer will be spironolactone and supplements, and we'll enter the fall with finasteride. And so I look forward to you joining me for these very fascinating studies that are really changing the world of hair loss. And I'll look forward to seeing you again next week for another episode of the Evidence-Based Hair Podcast.